Thank you. I'd like to thank the organisers for inviting me to give this presentation, which really fits in very well with the last presentation. And I want to take you on a journey which many of you in the audience, I think, have been involved with as contributors to the OMRAC process. Well, we finally get it. Here we are.
Do you want to part this picture?
No, I'll be fine. Thanks. Probably nobody heard that, but anyway. I want to take you through these issues. Just a very brief definition of OMRAC, which is really looking at outcome measures and fits in very well with the previous speaker. Talk about the history, the sort of what we're planning in the future, and then tell you a little bit about how OMRAC works, because it is another sort of network. It's an affiliated organisation with the BJD. It started back in the early 1990s when really it was clear that with a number of outcome measures, particularly for diseases like rheumatoid arthritis, there was really no consensus over which measure one should use in a particular clinical trial. If we don't have some sort of consensus for the use of these outcome measures in clinical trials, then it's very difficult to compare them across countries, within countries, between trials, etc. And there was also, I think, at the time, a very intense transatlantic divide. Now, of course, that doesn't occur now, as the Atlantic has been bridged, but there was in those days, and I think that it was actually people like Peter Tugwell and Martin Bors, who Martin was doing a sabbatical with Peter. They sat down and they started to think about how they could bring these two groups together, EULAR and ACR, at least try and get some sort of consensus between the clinical trial measures that were used on both sides of the Atlantic. A number of meetings were held before OMRAC 1, both in Hamilton, in London. It was felt important to look at OMRAC 1 was held in Maastricht. It looked at this core set for rheumatoid arthritis trials. The important thing to do that it focused on was could we use composite measures? What were the sort of improvement criteria? And it really led to the global assessment. It led to the development of this core set. I'll tell you about how the core set's actually arrived at. But one of the other important things that we were able to do in the early days was to take the core set of measures, take them to WHO, and then get them signed off by a joint meeting of both WHO and ILAR. And in terms of the core set in RA, it was felt that we should be using the global assessment, both patient and assessor, pain, painful joint count, swollen joint count, physical disability, and the acute phase proteins. And in fact, in studies that went for more than 1 year, it was felt that one needed to have some sort of X-ray measure as well. OMRAC conferences went on from that. In OMRAC 2 looked at cost effectiveness and was where we started to develop task forces. That was groups that worked between OMRAC meetings. OMRAC 3, we looked at setting up core sets for osteoarthritis and osteoporosis, and looked at some of the important psychosocial measures, and that was held in Queensland. OMRAC 4 explored core sets in diseases like lupus erythematosus, ankylosing spondylitis, and looked at outcome measures that could be used in longitudinal and observational studies. And again, this was the OMRAC where we really started to look at imaging, focusing much more on imaging at OMRAC 5, but also developing the issue about drug safety, a very important issue, obviously, in drug trials. OMRAC 6 went back to Australia. In fact, all the OMRAC meetings, as you know, go from Europe to Australasia to North America. They rotate at two yearly bases. OMRAC 7 was held in Asilomar in the United States, and this was where we started to get this idea of having what we call SIGs, special interest groups. A module at OMRAC is a group that runs for 3 hours and has formal voting. If an outcome measure is put to that module and it scores more than 70% of the votes, then that will become a core measure. Workshops run for 2 hours and really are sort of preliminary to developing a module. Workshops are preliminary to developing a module, and then the SIGs were developed as really special interest groups. They run for about an hour and a half, and they're really very preliminary. They're bringing up an issue that people feel is important in terms of measurement of clinical trials, and then if they're successful, they will work through a workshop and then a module. The other thing that happened at Asilomar, which has been very important to the OMRAC process, was actually the involvement of patients. That again was probably something that really grew out almost of the BJD, because it was about the same time that the BJD was being talked about and being developed. And of course, one of the great strengths of the BJD has been the involvement of patients. And then OMRAC 8 was held in Malta, looking at early response. OMRAC 9 was at Kananaskis and had one module looking at fibromyalgia, a series of workshops where we first developed this idea of having a patient perspective, and then a number of special interest groups on a whole range of topics, include from basic science, looking at synovial tissue, through to what about flares in arthritis, the issue of MRIs, joint space measurement, all sorts of things like that, and a Fellows Training Day. And I must say that the Fellows Days have been extraordinarily beneficial. What OMRAC has tried to do is grow a cohort of workers or researchers in outcome measures, and those fellows have been supported both by the OCR and by EULAR. And we also held at this meeting at Kananaskis a meeting looking at risk and benefit, which was a pre-meeting where we had input from the FDA and a number of the other major drug regulatory institutes. And then OMRAC 10 was held at Kota Kinabalu in Borneo. Again, we had a slight variation, as well as the normal modules, module updates and workshops, and the special interest groups. And you can see that we're actually expanding things to look at things like health literacy, very important as we go into the future, and we think more about prevention and people looking after their own diseases. And even venturing into orthopaedic surgery here with joint replacement therapy. Again, a very important endpoint, obviously, in diseases like osteoarthritis or rheumatoid arthritis. We also held the Sharp Symposium, which was focusing very much on imaging. John Sharp, as all rheumatologists in the audience will know, was one of the fathers of musculoskeletal